All right, guys, we're going to get started with our last lecture for the day, so wellness. Nice. All right, let's go. Huh? You are unmuted. You should be unmuted. Let me check.
Okay, guys, so I'm Neve, one of the third-year residents, and we're going to be talking about conflict de-escalation, or what I like to think of as escalation of de-escalation techniques. So special thanks to the Wellness Committee for looking over and helping me the lecture, Drs. Willis, Stetz, Wolfram, Dr. Ahmad, Dilla, Chow, and Berlin. So Surya, Manisha, Priscilla. So our objectives for today are identifying agitation and goals of working with an agitated patient, understanding how to assess agitation objectively with the bars, 10 approaches to de-escalation, and alternatives when words are not enough. So it's right before your shift, you show up early and you see that the PCA dropped off someone to 17 hallway. And being the nice resident that you are, you want to pick them up and go over to see what's going on because you hear them yelling. And you walk over to this, which quickly turns into this. And you're just like, what do I do to stop this situation from turning into this? Or having to use these. So we can consider agitation as a continuum, which ranges from anxiety to high anxiety to agitation to aggression. More specifically, this picture is by Ruben Strayer. So he described it in MRAP and then later in April 2020 in EMCrit as 3 different categories: agitated but cooperative, disruptive without danger, and disruptive and dangerous. When we identify these patients, what are our goals of de-escalation? So there was a 2012 paper in the Western Journal of EM that challenges the previous traditional goal of calming the patient, which often can have a dominant submissive connotation. And instead, they suggest that we should have a contemporary goal of helping the patient calm themselves, which is more collaborative. The paper mentions that there's 4 objectives to de-escalation, to verbal de-escalation. One is to ensure the safety of the patient, staff, and other members of the area, help the patient manage their emotions and distress, and maintain or regain control of their own behavior, avoid the use of restraints when at all possible, and avoid coercive interventions that can escalate agitation. So now that we know how to identify this patient, can we quantify it? So traditionally, many people use like the RASS scale to identify like agitation and sedation. But there was a 2001 study that sought to identify a suitable rating scale for behavioral activity. So this behavioral activity rating scale called BARS was created in a clinical trial that was studying ziprasidone in acutely agitated or unstable psychotic patients. So they looked at 3 different clinical trials, and this is how they rated them, between 1 to 7. So 1 is kind of like that difficult or unable to arouse patient, it's a very low GCS. 2, asleep, but responds normally to verbal or physical contact. 3, where the patient may appear drowsy or sedated. 4, they're quiet and awake, which is a normal level activity. And then 5, where a patient may show signs of overt physical or verbal activity, but they calm down with instructions, which is our agitated but cooperative group that we talked about before. 6, which is extremely or continuously active and not requiring restraints, which is our disruptive without danger. And then 7, requiring restraints, which is our disruptive but dangerous. This study had some limitations. It was a clinical trial based out of Pfizer, but it did show good intercoder reliability when they were rating. But again, there was very specific people who were documenting these scores, and there hasn't been any external validity of this rating scale and how it can be used in like the ED or the clinical setting. So now that we've identified this patient, what do we do? So in 2012, there was a paper that came out that described verbal de-escalation in the agitated patient. It was a consensus statement of the American Association of Emergency Psychiatry and this Project Beta de-escalation work group. So they describe 10 domains of de-escalation, which have gone into practice in many clinical areas, and we're going to go in and talk about them right now. As is important to note, every patient should be dealt with like in an individual approach. Many of these patients who are agitated may have an underlying medical issue. Are they hypoxic? Are they hypoglycemic? Are they encephalopathic? And given those different situations, a lot of these verbal approaches may not be appropriate. And also, if they're at the end of the spectrum when we talked about that disruptive and dangerous, these verbal approaches may not also be used. But this is just something to consider, and then escalate this de-escalation as we continue to go through the 10 steps. So number one is respecting a patient's personal space. So it's important to maintain at least 2 arms length distance between you and the patient. This is good for providing the patient the space that they need, but also it protects the clinician if they need to get out of the way or if the patient were to kick. It's also important to note that respecting a personal space is also very patient dependent. If there is an undomiciled patient, they may be very sensitive about protecting their belongings, so it may be important to not move that away or not have that out of their sight. If there is a patient who's been sexually abused and they're being seen for that, it may be very important to know that they may be apprehensive about being unclothed, and that can increase their sense of vulnerability and make them feel humiliated. Number 2 is don't be provocative. I think this one is pretty important because oftentimes we see that patients can get increasingly agitated by their interactions with different people. So it's important to use body language that suggests that we're not going to harm the patient and that we want to listen and that we want everyone to be safe, including ourselves, but also including the patient. So this can mean making sure that your hands are visible. So if you avoid concealed hands, standing in a manner where you're not directly, face to face with the patient, maybe stand at a little bit of an angle, and not giving too much eye contact. So direct eye contact, especially staring, can sometimes be interpreted as an aggressive act. It's also important to monitor closely the other patients and individuals that the patient is interacting with. So if there are a lot of people walking by, or if there are other patients who are yelling or shouting at the patient, that can also further their agitation. It's also important not to challenge the patient or insult them, or do anything that can be perceived as humiliating, because humiliation is an aggressive act, and the person may feel threatened that their integrity or their very self may be threatened. And in these cases, humiliation in itself can be very traumatic for patients. Next is you want to establish verbal contact. So ideally, this is going to be the first person who interacts with the patient. But I know for us, a lot of these patients have gone through triage, and no one in our ED really has formal training for this. And it's something that you can work on. Us as a provider can take on the role to be that sole person to have verbal contact with the patient. We should introduce ourselves and provide reassurance. A good strategy is to tell the patient your name and your title, and then rapidly diminish their concerns and explain that we're there to help keep them safe, and we don't want any harm to come to them. If the patient is very agitated, we may need to reassure them that we're there to help them regain control of the situation. Although we sometimes prefer to call patients by their last name, sometimes this can be seem a little patronizing, so it's important for us to ask the patient, what do you prefer to be called? And this allows the patient to have some choice, and it kind of gives them some control over the situation from the very beginning. Like, this person is listening to me, and they're allowing me to make these decisions, and then they're listening and acting on what I want, which is really important. Next is to be concise. So we want to use short sentences and be brief, use simple vocabulary. We don't know what's going on with these patients. They may have a lot going on, and if we're giving them a lot of information at once, they're not going to be able to really follow what we're telling them. It's going to also be important to repeat ourselves, especially when we want to make requests, making sure we're setting limits, offering choices, and proposing alternatives, so the patients know exactly what we're saying, and sometimes they need it to be said a couple of times. Number 5 is we want to make sure we identify the wants and the feelings of the patient. So whether or not we can provide the patient with what we want, it's important for all patients to be able to express their wants. So we can use statements like, I really want to know what you expected when you came here. And this might not be true because many patients didn't choose to come. Someone might have forced them to come to the hospital. And then you can also add a caveat like, even if I can't provide it, I want to know so that we can work on it. And that way they know that at least you're interested in knowing what's going on with them. It's also important that we just respond empathetically and allow the patient to know that we express a desire to help them to get what they want, even if we're unable to do it. Active listening. So once a patient has told us what they want, we can respond with active listening. Like, I want to make sure I have a good understanding of what you're saying. Tell me if I have this right. And it's also important with these patients to assume that what they're telling us is accurate when we're engaging with them. And this is a true situation I had. So even if you have a patient who thinks that their neighbor is shooting lasers at their legs to slow them down, and they come to KCHED and they wrap themselves in aluminum foil, you kind of have to put yourself in their position. If you really thought that someone was doing that, like, you can understand why this would be very concerning and why your plan to work them up for other reasons of their leg swelling to them may seem a little ludicrous, because they're like, I know what's going on. And you have to also, so you have to kind of imagine how this could be true from the patient's standpoint and engage the patient in the conversation as to why this is happening to them, and convey that you understand that it could be upsetting to them when you're de-escalating the situation. 7 is to agree to disagree. So there's 3 different ways that you can agree with the patient. The first is agreeing with the truth, which may or may not be the case. So if you don't think what the patient's saying is the truth, you shouldn't agree with what they're saying, but you can agree with their principles. So if a patient who is elderly and demented is convinced that their daughter or son is poisoning them, you can respond to saying, everyone deserves to feel safe at their home. That's an empathetic way to respond without necessarily saying, oh yes, I agree with you, this is what's going on, if that's not the case. And the third is to agree with the odds. So you can say something like, there are a lot of other people who would be upset too if they were in your situation. Number 8 is to lay down the law and set clear limits. So it's critical that the patient be clearly informed about what acceptable behaviors are. We should set limits and demonstrate our intent. And we should acknowledge that if our patient is causing us to feel uncomfortable, we have to tell them. When we're telling them this, we also need to add saying that our desire to help them can be interrupted or derailed if this type of behavior continues. So if I feel angry or fearful, these good working conditions require that we both treat each other with respect, and we may not be able to work on this shared goal that we have of helping the patient kind of regain control of what's going on. And once we have established this relationship, we can coach the patient of how they can stay controlled. So it's important for us to offer choices and optimism to the patient. So choices can be a source of empowerment for patients who believe that physical violence may be a necessary response. And offering a choice can be a powerful tool. Sometimes, we offer choices when someone's agitated just by offering them like a sandwich or a drink, and that helps us actually does help us buy time. But it's important to note that we shouldn't offer choices or provide patients with options that we know are not realistic. So we can't say, oh, if you let us draw this blood, I'll let you go outside for a smoke, because we're not going to do that. And that creates a false sense of hope and then can ruin their relationship later on. Or say, their patient's like, I just want to go home. And you can't say, oh, well, we're just going to have you talk to the psychiatrist and then we're going to send you home, because that's not necessarily true. Think that they're in any twisted have to be admitted against their will. We don't really want to provide them with inaccuracies of what could potentially happen. So when medicating a patient, which is usually when we see the first group, which is the agitated but cooperative or the disruptive without violent, you want to see if the patient can, when broaching the topic of medication, you want to see if the patient can bring up this topic themselves. So the goal of medicating these patients is not to completely sedate them, but we want to calm them. We want to remind them that we want to give this medication so that they can be calm and they can take ownership of what's going on. So sometimes we should just ask patients questions like, what helps you at a time like this? And if that's, sometimes many patients will actually say, I need the medicine. Like, I had a patient who was here a few weeks ago in Kings County who was really drunk, and she just kept on yelling, like, I need the medicine, I need the medicine. It was almost like she knew that when she gets really agitated when she's drunk, she needs that. And we wanted to give that, but it was helpful for her to suggest it herself, so that when we gave it to her, it wasn't a fight. She took the medicine, I think Bing gave it to her, and she was very appropriate. We didn't have to call HP. to hold her down. She went to sleep, and then we were able to continue with the rest of the workup. If the patient is not offering it themselves, you can always suggest something like, I see that you're quite uncomfortable. May I offer you some medication and see if that helps? And that's kind of like stating a fact. Next, you may have to go into the strategy of persuasion, which is, I really think that you need a little bit of medication. We're going to order you something. And then the last is when the patient is denying it and you have to give it, which is our typical patients when we have to call HP and have everyone kind of on board to say, I have to give you this medication. Like, no, we're in a really dangerous situation and we're worried that you could be a harm to yourself or others. And sometimes I think that in the ER, and I fall into this trap, I don't do a good job of verbalizing and communicating to the patient of what's going on. And we kind of just call HP and we say 5 and 2, and like that is something that we're aware of, but not everyone in the situation is aware of what that means. And I think it's really important to disclose both prior to and after the situation when you debrief, and we'll talk about that in a bit, both with staff and the patient about what went on. But it's important to keep the patient in the know. Even if you're doing something that they may not want, you still have to let them know what we're doing and what we're giving them and why we're giving it. And that might help them work with us a little bit more. So when talking about this escalation and de-escalation techniques, the first 8 domains of de-escalation were mostly verbal. And now we're going to kind of switch into the realm of chemical, go into physical. So let's go back to this diagram that we saw initially when I was talking about Rubin-Strayer and focus now on the bottom half. So we had talked about the agitated but cooperative, disruptive without danger, and disruptive and dangerous. So patients who are agitated but cooperative, they might be amenable to the prior mentioned 10 dimensions. And then we get to the group of patients who are disruptive without danger, who may require that discussion explaining that they may benefit from medications. Traditionally, we have, the 5 and 2 that we always talk about, but oftentimes, this 5 and 2 IM can take a long time to take full effect, and it might not even provide adequate sedation. So there's a drug written on this picture, droperidol, and I know that when I was doing the research for this presentation, I certainly did not know what it was. So what is droperidol? Droperidol, by the way, is available at Kings County. I'm not sure about downstate, but it's not available at Pyxis. So you have to order and get just a little bit of background. So droperidol is antipsychotic, similar to Haldol, which was often used for nausea and vomiting, but it fell out of favor in 2001 after the FDA released a black box warning that it might cause QT prolongation after there were a few case reports of such effects. But when talking about this, it's important to think about the evidence. So these were based on case reports, and since then, there have been some randomized control trials, most of which were out of Australia. So in 2010, there was a blinded randomized control trial of IM sedation for violent and acute behavioral disturbance, and they compared droperidol 10 IM to midazolam 10 IM to a combination of 5 and 5, each droperidol or midazolam. And it was out of New South Wales and Queensland in Australia, and it was known as the DORM study. So inclusion criteria were patients that were requiring physical restraint and parental sedation. IM droperidol and midazolam resulted in a similar duration of violence and acute behavioral disturbance, but more additional sedation was required with midazolam group. Midazolam also was found to cause more adverse effects because of oversedation, and there was no evidence of QT prolongation associated with droperidol when compared to midazolam. In 2017, the Annals of EM published another randomized control trial, this time comparing midazolam and droperidol 5 and 5 to droperidol monotherapy, also 10, to olanzapine monotherapy of 10 IM. This study was a randomized controlled, double-blinded, triple-dummy clinical trial in the EDs in 2 inner-city tertiary referral Australian hospitals. And enrollment was based on patient and staff safety considerations and not on any type of sedation score. 10 minutes after the first sedative dose, significantly more patients in the midazolam droperidol group were adequately sedated compared to those of just the alone droperidol group and the alone olanzapine. So given this information, what should we consider? So there's different realms of different medications, and it often does rely on the patient, but with this information, I think that we should consider giving droperidol either as monotherapy or in combination with midazolam. So some of the benefits of midazolam over Ativan IM are that it's much more fast and reliable. However, it can still cause respiratory depression. So if you're using either midazolam or olanzapine, it's really important for us to start respiratory monitoring for these patients because everyone's going to react differently. We still have the Haldol and midazolam or Haldol and Ativan option, but we have to note that it's going to be slower than the other choices. Usually with Haldol, it can take over 30 minutes. Same with olanzapine, it's a little bit shorter, but droperidol, the time of onset was usually like around under 20 minutes, which is a lot faster than what we're used to, especially in times when we want a patient to be kind of more compliant and work with us sooner rather than later and having to escalate the treatment. So like we said earlier, there are many special considerations. So we want to avoid antipsychotics in patients with drug use or patients who are agitated due to ETOH or drug withdrawal. And the elderly, and they kind of talked about this in the farm lecture earlier, you know, benzodiazepines can have an extended half-life and they can cause oversedation. We often try to stick to antipsychotics with these patients, with elderly patients. In 2002, there was a Cochrane looking at 5 randomized control trials, and they found that Haldol actually didn't provide any improvement in agitation among demented patients when compared to a placebo. They had some side effects. RCTs are really strong for risperidone. In 2003, there was a randomized double-blind placebo-controlled trial in the Journal of Clinical Psychiatry that showed significant improvement in aggression and agitation and psychosis. However, this is more something that's an everyday thing. For PRN, they still recommended like trazodone and lorazepam, and I know that we still give like olanzapine a lot. For those patients, I think a lot of the non-pharmacologic things that we should consider are, you know, decreasing overstimulation, light, and I know that in our hospital it can be a little more difficult, but maybe trying to work with the nurses to see if we can get these patients, you know, out of sharing a room with someone who maybe is very drunk and agitated, because the combination of those two people together may not be really beneficial for both the patients and for the work environment. So now we get to the patients who are disruptive and dangerous. So for these patients, like I said, it's always really important to know if there's an underlying issue. Because say you have a patient who maybe you're concerned because they have significant trauma, or you're concerned because they might be very sick. So Ruben Strayer, going back to his talk, he talks about this ketamine litmus test. So the ketamine litmus test is kind of saying, would you be willing to intubate this patient? Like, are you concerned enough about their medical condition that you would intubate them? And if that's the case, then you should go through with ketamine, because obviously the downside of ketamine is that you could potentially oversedate them, or they could have the hypersalivation or the spasm, and they could have to be intubated. So when you have these patients who are very dangerous, and they're both a danger to themselves as well as the staff, it's important that you might have to use force as a bridge to using chemical sedation. If you're concerned about patients spitting and stuff, it's really important to use something like an oxygen mask rather than trying to cover the patient with sheets, which I've heard stories in RED that are happening. And then also changing how we view the use of restraints as more of a means to a bridge to sedation rather than like just sedating the patient. So I think that we're going to talk about restraints a little bit more further on, but if ketamine is your drug of choice, and for these patients, you're not going to have an IV because they're too dangerous to get an IV. So you're going to be using IM meds for these patients. For ketamine, you can use about 4 to 6 milligrams per kg IM. And if you need to, you might have to have loose restraints, PRN, but there shouldn't be a role for tight restraints. Elevate the head of the bed, and then make sure that you are putting the patient on the monitor, checking their temperature, looking for all those reversible causes or medical causes that may require further workup. like hypoxia, hypothermia, hypoglycemia, hypoperfusion, hyperkalemia, acidemia, intracranial hemorrhage, CNS infections, withdrawal, thyroid toxicosis, rhabdo, oral shock. So when we work with these patients, some of these patients, a lot of the techniques that we mentioned may not work. So let's talk about a little bit more about aggression. So when we're dealing with an aggressive patient, it's important to set firm limits to protect the staff and other patients. There are 3 different types of aggression when you're describing it. So there's instrumental aggression, which is used by patients who have found that they can get whatever they want by being violent. There's fear-driven aggression, which is not really self-defense. It's that a patient may want to avoid being hurt or may attack to prevent someone from hurting them. With these patients, it's important to not show any signs of force in any way or intimidate the patient and make them feel threatened. Otherwise, you'll feed into their belief that they're going to be hurt, and then they'll further escalate their behavior. And then the third is irritable aggression, which can be seen in 2 forms. One is that the patient feels that their boundaries have been violated. Maybe someone's cheated on them, or someone's humiliated them, or they've been emotionally abused. And the second form is irritable aggression, which occurs in patients who are chronically angry and are looking for an excuse to go off. Unfortunately, with these patients, they will often test the limit by doing just what you've asked them not to do, and they will often require medication or physical restraint. So now let's talk about restraints. So I think that it's very common, especially like when I'm working in the ED, I almost get this like sense of like doom whenever I have to restrain someone. It's like you feel morally conflicted. Like, what else can I do to help this person without having to tie them down and then watch them struggle? So tight restraints are very dangerous. When you have a physically restrained person, they're still a threat to themselves and they still require sedation. So I think it's important for us to make sure that if we do have to restrain patients, they're not like awake and just shaking and squirming the whole time, because they can go into rhabdo. That can be really dangerous for themselves as well, or other people. They can flip the bed over. And we still have to continue doing the rest of our work and continue to help them kind of control their anger. Restraints often have like more of a punitive element at work, and we need to overcome this tradition. They should be used as, like I said, a temporary measure while attempting to use chemical sedation. So earlier this year, JAMA published a qualitative study, and they interviewed 25 patients who had physical restraint order in the ED. So this is just qualitative. It was just explaining how they felt. And many of them overwhelmingly described a desire for dignity, respect, compassion, therapeutic engagement, and attempts by staff to explain actions that were being performed on them, even if the therapeutic relationship had been fractured as a result. Most participants didn't present to the ED willingly, and they had already felt threatened prior to arrival. So without the psychological support of staff members during these restraint events, patients may spiral into negative emotions with subsequent ED visits and instinctively escalate short-term agitation when they present in a future visit. The final step, the final official domain, I should rather say, is to debrief the patient and the staff. So after any involuntary intervention with an agitated patient, we should start by explaining why the intervention was necessary and let the patient explain events from their perspective. You can say, what works when you're upset, as you were today? And what can we do in the future to help you stay in control, to prevent us from having to do or go down the path that we did if it was something that they weren't happy with? And also debrief. So we're getting a lot better at debriefing when it comes to like codes and adverse effects, but I think that we should also spend more time debriefing a lot of these agitated patients with the staff around us. So if we had to use restraint or force, or if HP got involved and there was something that we visualized that we weren't happy with, it's important for the staff to be debriefed on the actions after the event. So everyone should feel free to suggest both what went well and what did not, and so that we can recommend improvements for the next episode or the next patient. I think that that's something that maybe we can start to implement more. I know sometimes the nurses aren't happy with what we're doing, or sometimes the nurses want us to medicate someone because it's interfering with the work with someone else, or we see someone say something, and I think that if we do it in a more formal setting, it'll be more appropriate to say, hey, this is a safe space for us to talk about what just happened. Like, how about everyone say what they think went well, what they think didn't, and what we can do. And you can also, like I said, initially you can include the patient when you're trying to get some information, and then afterwards, if they're amenable, and then afterwards, obviously, mostly focus on the staff. And then number 11, which wasn't officially a domain, but it's something that I kind of made up myself, is to check in with yourself. So dealing with these patients can be very draining, can be very dramatic, and you can feel very defeated. And you also just feel like shit sometimes when you're like, man, I have to medicate this person, and then it's 7 a.m. and there's no way they're gonna wake up until the next shift, and you're like, did I do the right thing? Did I do the wrong thing? Could I have approached the patient in a different manner so that this wouldn't have happened, or tried to hold them off until psych came and saw them? And we have all these questions, but you just have to know that there's a lot of people, other people in your clinical area. So if you see another resident or someone, or ask, see how they're doing. And if you are having a difficult patient, just know that you don't have to make this decision on your own. Like, use your peers, use your attendings to ask. And you almost always, the attending is always included in the decision to use drugs, but also consider some of these alternatives that we talked about. And I also am going to work with, I think I'm going to talk to Dr. Bleeder to see if there's any way we can maybe consider getting like Droperidol or easily accessible, because I think that if we have to order it, it takes that long. It's not really going to make a difference if we're waiting for like an hour to get the medicine in this place. So this is just my people that I turn to when we need help, and these are the learning points. So I'm just going to talk about, thinking about agitation as a continuum, agitated but cooperative, disruptive, without danger, and then disruptive and dangerous. Starting with the 10 dimensions of de-escalation and involving the patient in their care when possible. Remember your alternatives to 5 and 2 and other causes of agitation, and sedate if needed. And having that threshold for ketamine and intubation if the patient is really a harm to themselves or is interfering with their workup and you think that there could be something dangerous going on. Number 4, using restraints as a last resort and more of a means to chemical sedation. And 5, debriefing with yourself and others involved. And
that was a great talk. I think the important thing to remember when you're dealing with an agitated patient is agitated patient does not equal agitated patient, does not equal agitated patient. You really have to think about why this patient is agitated. Are they agitated because they're just intoxicated? That's a very different agitated than somebody who's psychotic, who has no drugs or alcohol on board. I'm going to approach those patients individually, and I'm going to use actually different medications, because I don't think somebody who's drunk needs antipsychotic medications. I think they just need time for their alcohol to, and they don't need to metabolize completely. You just need to get past the excitatory stage of intoxication, because alcohol itself is a depressant. Sometimes you just need to buy yourself. That's why I like Versed for the intoxicated patients, because you give them a good shot of Versed, it helps the alcohol, it's already there, and then they just go to sleep, and they won't bother you, and they'll wake up, and they'll be like, okay, I'm ready to go. And then as opposed to the psychotic patient. And then there's the patient who's just upset. And sometimes they have a reason to be upset, like they're rightfully upset. Their reaction might not be appropriate, but they're rightfully upset. The cops came in and beat them up or arrested them for some ridiculous reason, and they're upset, and they're overreacting, and they're not acting appropriately, but sometimes it just involves a conversation. And seeing an agitated patient says, well, let's go grab the 5 and 2. You should always try to approach that patient and just say, hey, how can I help you? And they'll be like, oh, this guy, I'm like, don't worry about them. Let's just see how we can help you. And that goes a really long way with these patients. And really thinking about why they're agitated will help make decisions. And just grabbing the 5 and 2, which I'm not a big fan of admin, unless I really think I need a long-term sedation with that person. I'm going to go with Versed, and it should never be 2 of Versed. They're different medications, so you can't give 2 of admin and 2 of Versed. You should never be giving 2 of Versed to anybody you're sedating. You should probably be starting at 5 or more. 4, like that's 4 is like the lowest amount of Versed that you should be giving if you're trying to sedate someone.
I like 4. I don't like the waste medicine that comes in 2s. So either 4 or 6. But I really dislike giving ketamine to psych patients, because they have such an altered grasp of reality already. They can't figure out what's going on in the world. That's why they have psych disease. And when you give them a drug that makes them like it destroys their perception of reality. It's a psychotic drug. It really confuses them even more. And it may not make them more agitated, but it will make them more confused and more upset, especially when they're waking up. So I try and avoid it if I can in psych patients. I won't use ketamine for sedations in psych patients, even for like shoulder reductions. I think it's just a drug to avoid because they're so confused with reality already.
You know, I'm a crazy person, as many of you know. So sometimes I will go to some silly lengths just to kind of get the patient on my side, and we kind of gave the example of, you know, a patient want to have a cigarette. I've been known to do that. I've made a plan with them and said, look, you work with me, I'll work with you, go outside, you can have your cigarette break, and then I'll walk you back down.
I don't have a problem with that either. I do the same thing.
Yeah, and I've done that.
It goes a long way too.
Because sometimes it goes a long way, you don't even have to worry about sedating, things like that. Sometimes they just do need a cigarette. And I don't say, okay, let's go do that now and then find out. I make a plan with them. And sometimes I combine with confidence, they believe me, and I reward them by, yep, let's go outside and do it. So I'm not saying you can do that all the time. It can take a Herculean effort to de-escalate a patient early sometimes. But if you have the time to do it, it goes a long way, and it's just pleasant.
Don't do it patients you would think of faster than.
Yeah.
But I think a lot of people making the same point. You got to think about, you know, Dr. Haas describing is the goal of the person. But when you're dealing with a decompensated axis 1 patient is compensated because of organic function, maybe mild intoxication. That would be okay. But you got if you have like an axis 1 psychotic patient, going out for a cigarette's not going to stop. So I agree with Dr. Sharp. I think you've got to think about the etiology and figure out how you.
And whichever drugs you decide to pick, depending on the etiology, you decide you need a drug. Remember, if the elderly start low and go slow, you don't want to start with that full dose of 5 and 2 in an elderly patient, or whatever drug you're picking up, start in an elderly patient. As our speaker before, the pharmacist said, you can always give more, but it's hard sometimes to take back. And even though there's pressure on you, the nurse is going to push you and say, oh yeah, this person has to be knocked out or whatever. You still start slow and add on to it in the elderly.
And don't underestimate the power of asking the patient, can I give you something, even right? A lot of patients don't want to get an injection of medication. Sometimes you can talk to them and say, hey, kind of like with your 5-step strategy, right? You say, I can keep medication, or you like something. You can sometimes just give them a pill. Deal with it. It's great.
Yeah, if you take the pill, I don't have to give you a shot. Yeah.
Yeah, Risperdal.
Awesome. Good job, Minnie.